Okay, now we're moving. So just for those of you that are not familiar with BioVentures for Global Health, BVGH is a nonprofit organization that was founded in 2004 through a partnership with the Biotechnology Innovation Organization, BIO, and the Bill and Melinda Gates Foundation and the Rockefeller Foundation. And BVGH was established to engage the private sector with a focus on biotechnology, life science, and pharmaceutical companies in programs and partnerships to advance and improve global health. Our programs today all engage the biotechnology and pharmaceutical sectors through partnerships with governments, with nonprofit organizations, and by connecting people, resources, and ideas to solve critical global health issues. BVGH's work currently falls across three core strategic areas. One of those areas is expanding access to cancer medicines and technologies in Africa through our African Access Initiative program. We'll be speaking in depth about this program with you today. BVGH has a history working in the neglected infectious disease area, and our work in that program area falls under our WIPO research program. If anyone on this program is interested in learning more about our work in neglected infectious diseases, you can visit BVGH's website at bvgh.org, click on programs, and look at our WIPO research or other programs. And then the third strategic pillar of work is building biomedical research and development capacity in low and middle income countries. Our work in this area includes coordinating and managing fellowships, which engage scientists and experts in the private sector, so within pharmaceutical companies, also in academia, and we work with governments as well through our fellowship programs to share knowledge, skills, expertise across basic research, cancer patient management, and the strategic management of health systems. We also coordinate equipment placement and donation to fill gaps in laboratories, in research organizations in low and middle income countries. And then BVGH has also coordinated a multi-African country pavilion at the Bio International Convention. This is a convention that is the largest biotechnology life science partnering event in the world. And we've coordinated multiple African countries to be represented at that pavilion to explore partnerships with the private sector and with other research organizations globally. So we're here today to talk about cancer in Africa and our African Access Initiative program. And the reason that we are working in the cancer area is because Africa is today seeing a cancer crisis. Today in Africa, cancer kills more Africans annually than malaria does. And yet we typically are not hearing about the need to advance access to medicines, technologies, and capacity building in the oncology area in Africa. And there's a real opportunity to improve the capacity and access so that Africa can catch up to some of the higher income countries in being able to save cancer patient lives in their countries. And currently, cancer control lags far behind high income and wealthier countries. Unfortunately, in Africa today, late diagnosis is very common. Patients often present with late stage disease, stage 3, stage 4 metastatic disease, where a positive outcome is unlikely, even with treatment. And cancer is also unique in Africa with its strong connection to infections like HPV, HBV, and HIV. So understanding cancers in Africa are critical. There's a limited access to medicines, and where medicines are available, quality is often a problem. Diagnostic capacity across sub-Saharan Africa is weak, and as I'm sure many of you know, an accurate and timely diagnosis is critical to improving cancer patient outcomes. There's also a shortage of trained oncologists and healthcare professionals in Africa that have the expertise and knowledge to manage cancer patients. And research and clinical research is very limited across the continent, and yet critical to understand how to treat and manage cancer patients in Africa. And if anyone is interested in looking into some more information about some of these gaps and needs, you can look at our website and download a publication that we contributed to with other experts and partners in Africa from June of 2017 on the cancer situation in Africa. And based on all of these gaps and the need, BVGH designed and conceived of the African Access Initiative program. And we started thinking about how BVGH as an organization could engage our companies and our partners in having a direct impact on improving cancer patient lives in Africa. Our program is quite different compared to other global health programs in that we designed this program to focus on the priorities and interests of our partners based in Africa. So our process with the African Access Initiative began with engagement and partnership with governments, with ministries of health in country, with hospitals, and also with key stakeholders and partners. And we began this engagement well before we formally launched the African Access Initiative in June of 2017. We also recognize that understanding healthcare systems and how a healthcare system operates is critical to providing sustainable and scalable access to cancer medicines and technologies. So the BVGH team has mapped the healthcare landscapes and systems in our countries so that we understand the drug importation processes, the regulatory system, the payer system, and the supply chain system, so that we can inform companies of how they can safely and appropriately deliver their cancer medicines to hospitals and patients. We also have assessed cancer priorities at the hospital level, and I'll speak to our hospital level needs assessment. And our ultimate goal within the African Access Initiative is to strengthen healthcare infrastructure and systems and deliver drugs to cancer patients so that cancer patient outcomes in Africa are improved. Partners are critical to the African Access Initiative program. We work currently in 6 African countries, including Kenya, Cote d'Ivoire, Cameroon, Nigeria, Rwanda, and Senegal. We've also partnered with the African Organization for Research and Training in Cancer, AORTIC. If you don't know about AORTIC, I think it's a fantastic organization that is building connections across oncologists and researchers working in oncology in Africa. And AORTIC holds a biannual meeting every 2 years to bring together oncologists across the continent, healthcare professionals working in oncology, policymakers, and international experts to discuss research challenges, opportunities, programs. And so definitely an event worth exploring and participating in if you have an interest in cancer in Africa. And then core to all BVGH programs, we engage the private sector in partnerships and initiatives that solve these global health challenges. And funders are also a critical component of the African Access Initiative, both to fund the work of BVGH, but also to support some of the training programs and initiatives that we are implementing at the country level. So I'd like to take a minute to speak about the countries that BVGH has established partnerships with and how we select those countries and work with those countries. So as I said, we're currently working in 6 countries. We launched the African Access Initiative program at the Bio International Convention in June of 2017 in partnership with 4 of these countries, with Nigeria, with Kenya, with Cote d'Ivoire, and with Cameroon. And we select those countries and engage those countries with certain criteria and processes in place. The aim of our African Access Initiative program is to build a sustainable program to provide long-term and scalable access to the technologies and drugs that are needed. And so having a partnership at the Ministry of Health level in each of our countries is critical to aligning our AAI country activities with the goals and objectives of the Ministry of Health. So one of our first criteria is to have direct access to the minister and to confirm that he or she have a national cancer control plan and are investing in improving cancer patient outcomes in their country. So BVGH has met with the Ministries of Health in all of our countries. We've actually signed and put in place memorandums of understanding so that the ministry understands that our African Access Initiative is based on working in partnership with the government, also with the hospitals in the country, and that it's not a donation-based program. The African Access Initiative program is not a model that's focused on the donation of drugs. It's focused on providing more affordable, quality, and sustainable and scalable access to the drugs that are prioritized within our countries. Beyond working with the government, we have to identify and work with hospitals in the country that are already diagnosing and managing cancer patients. So our program is focused on building capacity where some capacity and infrastructure already exists. So all of our partner countries currently have hospitals and have healthcare professionals that are diagnosing and treating cancer patients. So as I mentioned, aligning our AAI program activities directly with the Ministry of Health in a country is critical to our AAI program model. And this slide presents the partnership that BVGH established with the Ministry of Health in Nigeria. And this is in early 2018 when the Minister of Health of Nigeria, Professor Isaac Adewale, the prior minister, is cutting the ribbon at the launch of Nigeria's National Cancer Control Plan. And BVGH is a key partner in that plan and uses and leverages that plan to inform our activities in the country. So once we've built that partnership and alignment at the government level, at the Ministry of Health level, we engage hospitals in each of our countries that are already diagnosing and treating cancer patients. And our hospital engagement process is also kind of a critical component of how we partner with our in-country stakeholders. And in identifying the hospitals that we work with, this can be guided by the Ministry of Health, who identifies and selects hospitals, but it's also been through partnerships that BVGH has developed in different parts of the countries that we're working in. So we do sign a letter agreement with each of our AAI hospitals, and we sign that agreement with the CEO or the chief medical director, the head of the hospital, so that we can engage across the different departments that are responsible for managing and treating cancer patients in the hospital. The hospital is required to conduct a needs assessment or complete a questionnaire, which is a comprehensive assessment that follows the cancer patient pathway through their presentation and diagnosis right through to clinical treatment at the hospital. And this assessment is the core tool that influences all of our programs at the hospital level in our countries. And so the data that we collect through this comprehensive assessment includes the number of cancer patients that are presenting, that are diagnosed and treated at a hospital monthly and annually. It captures those patients by cancer type, by stage of diagnosis, if that information is available. And then we follow the patient through diagnosis. So we look at the capacity, the infrastructure and resources in the pathology lab to diagnose patients. We assess the medical equipment that's required for treating and managing and monitoring cancer patients. We also gather information about cancer research at the hospital, international partnerships to support that research, any clinical trial experience in the oncology area. And we ask if there's interest at that hospital in engaging in research and clinical trials. We assess expertise across the oncology healthcare professional team at the hospital, so we have an understanding of the training and the knowledge both in the pharmacy, nursing, medical oncologists, surgeons, so that we have a good picture of the healthcare professionals and their capabilities and skills to manage cancer patients. And then lastly, we include FDA-approved cancer medicines by indication. And we gather information about the importance of those drugs for the hospital, but we also gather information about how the hospital procures those drugs. So does the patient come into the hospital with the drug? Is there an agent that those drugs are procured from? Or is there a relationship directly with a company outside of the hospital that's providing those drugs? About drugs, we also gather information regarding, are the drugs high quality drugs? Are they affordable drugs? And are they readily available for the hospital to procure? And then lastly, we ask, is it a priority for the hospital to have access to the specific drug for the approved indication? So with all of this information, and this is as I said, a comprehensive assessment of each hospital's capacity and current cancer patient management practices. No other organization has gathered this type of information at the hospital level to inform programs that are truly built around the priorities and needs of our partners at the hospital level. And once we have those assessments completed from multiple partners, partner hospitals, we then collate that data and And this graph presents an example of some of that collated data that can be shared back to the Ministry of Health to begin to have discussions about budgeting for treatment, prioritization of different cancers, and planning ahead to provide treatment options for these different cancer types. Determining which drugs by FDA-approved indication are a priority at the hospitals is also critical information to collate and share back with not only the Ministry of Health, but key stakeholders and agencies in a country. And the reason that we have breast cancer, cervical cancer, colorectal cancer, liver cancer, and prostate cancer captured here is because these are the 5 cancers in Nigeria that have been prioritized by the Minister of Health and in the National Cancer Control Plan. So these were the 5 cancers that we initially focused our access activities around, and these are the cancer drugs that have been prioritized by the hospitals. So with this information in hand about numbers of patients diagnosed by hospital and across hospitals in Nigeria, the drugs that are consistently being prioritized to have access to, BVGH then worked with the Minister of Health and his team to coordinate and hold a cancer stakeholder meeting. And this meeting was coordinated in Abuja in partnership with the ministry to bring the chief medical directors, the oncology teams together from the 8 federally funded cancer centers of excellence to define the treatment regimens, so the drug combinations, and the guidelines that would be put in place to treat the 5 main cancers in Nigeria. And we've taken a similar approach in our other AAI countries, but having those decisions made at the with the experts and the people that are actually treating the patients at the hospitals is essential to our model. For this meeting, BVGH also coordinated to bring experts from Memorial Sloan Kettering Cancer Center in New York so that they could discuss difficult to manage cases and provide some of their insights and experience in how to make a decision about treatment regimens and which patients to treat and how to treat those patients. So having that partnership with other more experienced oncologists is also something that helps to share knowledge and inform decision making. After the cancer stakeholder meeting, we worked with the ministry, the Minister of Health and his team, to develop requests for proposals around 41 prioritized cancer medicines, both innovative medicines and generic cancer medicines. And during the stakeholder meeting, we expanded beyond the 5 prioritized cancers to include hematological cancers, pediatric cancers, and head and neck cancer. And those cancers were prioritized by the oncologists and the CMDs, the chief medical directors, because they're highly prevalent cancers, and also from an ethical standpoint, the oncologists did not believe that excluding pediatric cancer was something that they could accept at their hospitals. So with 41 cancer medicines prioritized, we issued requests for proposals to 14 international pharmaceutical companies that had those drugs FDA approved, so we could be assured of high quality and a sustainable and scalable access program. And the responses that we got from the companies was really tremendous. Pharmaceutical companies offered significant discounts to their cancer medicines to make them available in partnership with Nigeria to Nigerian cancer patients. And we were just really impressed and pleased to see the commitment of all of the companies that we reached out to and connected with in making their cancer drugs available for patients in Nigeria. I'm going to turn this over to Dr. Farooq Mohammed so that he can speak about the work that we've been doing in taking this access program to 7 states in northern Nigeria. Farooq, could you pick up?
Thank you very much, Jennifer. First of all, I would like to start by saying that me and my colleagues in this part of the continent fully bear in mind that global cancer incidence is expected to dramatically increase within the next decade. And low and middle income countries, including Nigeria, which is one of the most populous countries in Africa with about 200 million population, expected to contribute significant proportion of this cancer mortality and perhaps incidence. Northern Nigeria is made up of about 60% of the entire Nigerian size and perhaps population, and it is intertwined with diverse culture, language, religion, and forms the least educated part of the country, ravaged by poverty and diseases such as cancer. Majority of the population in the northern Nigeria lives beyond $3 per day. These challenges are further compounded for cancer patients in northern Nigeria and perhaps the entire sub-Saharan African countries by lack of access to quality cancer drugs and technologies such as radiation therapy machines and diagnostic tools and reagents. In the northern Nigeria, for example, the only active cancer center we have with LINAC is the National Hospital in Abuja. Sokoto does have a LINAC, but it has been off and on because of the burden. So in eastern part of the country, for example, we are not aware of any available radiation therapy machine functional, whereby in southern part of the country, only Lut indicates to have active LINAC. I mean, Lut Lagos University Teaching Hospital. That of Ibadan have a cobalt machine for radiation therapy, serving millions of people. In line with this fact, the WHO noted in January this year during the launch of LOME initiative that more than 1 in 10 medicines in low and middle income countries is either substandard or falsified. And this includes significant portion of cancer medicine, such as leukemia drugs that were found to only contain paracetamol in some part of the continent. While this threat is a global threat, African countries bear the heaviest burden. The WHO DG further noted during this meeting that substandard and falsified medical products only exist because access to quality and affordable medicine does not exist. To address these challenges, the Federal Ministry of Health of Nigeria gave a nod to BVGH to move ahead and start working at state level. And at this juncture, we were able to coordinate the entire northern Nigerian region under the umbrella-ship of Ahmadu Bello University in Zaria towards driving this access program faster. We first arranged a meeting in September 2018 between top executive of Ahmadu Bello University and Ahmadu Bello University Teaching Hospital, as seen in this picture, with Jennifer Dent in Abuja to sign a memorandum of understanding, which focused on the access program, oncology, capacity building training and other parts of cancer management. Next slide, please. Part of this training effort, the BioVentures for Global Health under the African Access Initiative facilitated our collaboration with Emory University Winship Cancer Institute, where we are working on avenues that will provide opportunities for training of different subspecialties of cancer management in Africa at Emory University. I will discuss about this later during this presentation. Next slide, please. In the northern Nigeria, what we did under the umbrellaship of Ahmadu Bello University was that we were able to coordinate 7 states that have active cancer centers that includes the Ahmadu Bello University Teaching Hospital, the Aminu Kano University Teaching Hospital in Kano, the Usman Danfodio University Teaching Hospital in Sokoto State, the University of Maiduguri Teaching Hospital in Maiduguri, the Abubakar Tafawa Balewa University Teaching Hospital in Bauchi, the Federal Medical Center in Gombe, and the Federal Medical Center in Bidda, to come together and move this access program forward. So as previously said by the first presenter, Jennifer, of the 41 prioritized cancer drugs identified, RFPs were issued and a budget was developed to treat about 2,116 cancer patients in the northern Nigeria annually. Then the first thing we did after developing this budget was to think of a good model that brings in the traditional rulers, the local philanthropists in the region, the state government, and to larger extent even the national health insurance scheme of the country to come together so that a model can be developed for the sustainability of the program. But before doing this, we thought of one of the key things that moves this type of program forward, which is transparency in terms of financial management. So in this regard, we propose that an account would be developed for the program in the northern Nigeria under the Central Bank of Nigeria. By having this account in the Central Bank of Nigeria implies that any monies sourced out from these stakeholders will directly go to this mother account in the Central Bank of Nigeria for the onward payment to the pharmaceutical companies who have provided a very subsidized quality cancer drugs for the object of the program. And in addition, this account will also receive directly the percentage agreed for each patient to pay, be it 5%, 10%, or 3%. By the time the patient pays this money to any of the institution, the money goes directly to the central bank account. The money goes directly into the central bank account for sustainability. So after this model, we actually brings in 2 additional important key part of this program that include the training aspects, because whenever you are talking, our issue is not only the minimal access to cancer drugs in this part of the country. One of our key issues is training, the lack of training. So we, together with the African Access Initiative under the BVGH, we were able to bring in an idea that comprises of collaborating with Memorial Sloan Kettering Cancer Center in New York, the Emory University, and the Dana-Farber Cancer Institute to train different subspecialties of cancer management personnel in Africa in these institutions. This training was actually divided into long-term training and short-term training. Then another key important thing is the research aspect, because whenever you are talking about cancer treatment in Africa, you can't do that alone without including research aspect. Research aspect that informs to understand the genetics and the molecular biology of the cancer in Africa, in African population. So in doing this, we were able to develop an arm in this design that includes evaluation and reporting. Under this evaluation and reporting, we have subheadings that focus on biobanking for tissues and blood. This entails that any patient recruited to benefit from this program will be followed longitudinally by collecting the available samples of blood so that we can be able to understand the effect of these drugs in our population. We also included a subheading that covers data bank, information data bank for patient outcome, and then adverse event, which will be reported to the Federal Ministry, Nigerian Federal Ministry of Health. So what I want you to understand here is that we fully believe that at the end of the day, we will be able to provide an avenue whereby a very poor African patient who lives under $1 per day and is diagnosed with, say, breast cancer or liver cancer, for example, can be able to have direct access to affordable and high quality cancer drugs and technologies in our environment.
Thank you very much, Farooq. So I would just like to close the presentation aspect of our program today. And please, if you have questions, you can send those questions in the chat box through the drop-down menu. But just to give an overview of where we are right now and what our next steps and plans are in Nigeria, and also to share some of the lessons learned from our work in Nigeria through the African Access Initiative. So some of the lessons learned, and I think it's quite clear through the graphic that you see on the slides right now, is engaging the right stakeholders in an access program at both the government level, the policy level, hospital level, is critical to developing and implementing an access program that is going to be sustainable and that's going to build on the current infrastructure in Nigeria. So engaging organizations not only at the Ministry of Health, but also the National Health Insurance Scheme, the Central Bank of Nigeria, funders and state government leaders at the country level have been critical to designing and advancing our plans in northern Nigeria. And keeping those partners informed and apprised of the plans, the timing of our access program, are also critical. And our next steps in Nigeria, right now, we have this model set to go. We have funding committed at different levels in Nigeria. We are in advanced discussions in engaging the NHIS. And our plan now is to place the first order for cancer medicines, get those drugs to the Ahmadu Bello University Teaching Hospital and to Kano State, and to actually start the process of treating these 2,116 cancer patients. So I'd like to, I'm just going to put my video on. I see that, that Farooq has his video on as well. And we'd be happy to entertain any questions that participants have Thanks very much for staying with us and for your attention during this session. Does anyone have any questions? Do you see the chat box or to share and send questions to either myself or to Dr. Mohammed?
Hi, can you hear me?
Yes.
Hi, good morning from New York City, and thank you for the presentation. I really enjoyed it and very informative.
Could you introduce yourself?
Yeah, I was going to. You beat me to it.
Okay.
My name is Emmanuel Obasuyi. I'm from Nigeria. I live and work in New York City. I'm currently putting together a health tech platform for people to find and book their healthcare visits, a digital platform. So you can call it a ZocDoc in emerging markets. We're piloting in Nigeria, working with 2 hospitals right now in Benin City to help drive up their retention rate. Looking at the non-communicable diseases in Nigeria or in Africa, it's on the rise. And to see what you're doing is very inspirational, and is also confirms the need to drive down these numbers. And I would love to partner with you as we develop our platform to educate the population about the services that you provide.
Well, Emmanuel, we'd be very interested. I mean, partnerships are central to BVGH's model, to our work through the African Access Initiative. We'd be very interested in connecting with you outside of this session to learn more about your platform. And there are a number of activities within our African Access Initiative that we have not taken the time or had the time to discuss today. But one of them is in working with the government of Nigeria on leveraging technologies to streamline supply chain management, and also to consider technologies and platforms that can be used to actually track and monitor cancer patient outcomes and provide information to patients. So we'd love to hear about your technology and how we can potentially partner and work with you. Thank you.
Thank you.
So there's a question, and Farooq, I think you could take this. It says, thank you for the wonderful presentation. Please, are there plans for expansion to other centers within the North, like the state teaching hospitals? I think that's a great question. Maybe I'll start, Farooq, and then you can pick up. But any hospitals in Nigeria that are currently diagnosing and treating cancer patients can reach out directly to BioVentures for Global Health and express your interest in participating in the African Access Initiative. There is the requirement to have the engagement of the CMD of the hospital, and also for the hospital to take the first step of conducting and completing the needs assessment. But we'd be happy to engage new and additional hospitals in the North.
Yeah, actually, perfect, Jennifer. And I would like to tell the questionnaire that we have that plan already. In fact, that plan is already incorporated because by virtue of the fact that all the Northern Governors Forum have been briefed about this program for possible contribution, implies that every state in the northern part of the country can key into the program directly based on the contribution of and willingness of that state government. And then in addition, it's not that the program is only limited to the northern part of the country. We were already in active discussion with other parts of Nigeria, like the eastern and western part of the country, where we advise them to look at this particular platform and also carry on from there to replicate the same type of platform in their part of the in their institutions.
Do we have other questions, either through the chat or you can unmute yourself, as Emmanuel did? We'll just give people a moment to consider any questions. Farooq, maybe in the meantime, while we're waiting for questions, you could take a moment to speak about the importance of engaging the governments in both Kaduna and Kano states and the importance of their engagement and partnership in this program.
Yeah, so the importance of engaging the government of particularly Kaduna and Kano state is that the entire program comes in the form of very subsidized list of quality cancer medicine, where because it's not a donation, so we are expected to pay the remaining portion to the companies directly for our patients to benefit. So we have been engaging the state governors to look at the avenue of contributing beyond the budget, additional funding. If for Kaduna State, for example, wish to just contribute, let's say, particular amount of money for its own citizens in this program, there's that room that their own citizens stand to benefit a more subsidized, instead of paying, for example, 5% of the entire amount of the drug. If a governor decided to say, well, I'm taking off 3% further, that implies that cancer patient from that state only have to pay 2% of the entire cost of the treatment. And these are one of the things that we have been trying to sell to the governors. And one important thing in addition is that the way we design the program, we design it in such a way that the program can be able to actually be active for a long period of time, whether we are there or we are not there, because by virtue of bringing the Central Bank of Nigeria and then domiciling it within the facilities available at the government institutions, implies that you don't need to spend extra amount of money to recruit other specialists to carry on this program. The program is indirectly built into the available government institutions in the country, so we don't need to be there. I don't need to be there. Prof. Olasunde or Prof. Adamu don't need to be there for the program to succeed.
Thank you, Farooq. And we have another question from Benedict Aleda. He's a Nigerian and medical lab scientist at Duke Hospital over the last 12 years. And Benedict's passion is to give back and wanted to ask if there are plans for providing training in Nigeria. And Benedict, training and capacity building, particularly at the lab level, is a central part of our African Access Initiative program. BVGH has been working with partners like the American Society of Clinical Pathology to design and implement laboratory training programs to strengthen cancer patient diagnosis. And we're also always interested in, particularly Nigerians or Africans of from different regions and countries participating in those training programs. So we would certainly be delighted to hear from you offline and to see if there might be opportunities to engage in partnerships with Duke and yourself to support some of the training and learning needs in that area. And then there's another question here from Thelma. She says, thanks for the presentation. I would like to ask if there are plans to improve access to more novel treatments used in high-income countries for treating cancer. Some of these medicines haven't lost their patent yet and may be a bit more expensive. Is there a plan to bring in more of these drugs? Absolutely, absolutely, Thelma. Our access program is not only focused on some of the older generic chemotherapeutic agents, which are critical to treat cancer patients, but we're not limiting the African Access Initiative access program to those medicines. We've reached out to the international pharmaceutical companies that own the patents on some of those more targeted, newer cancer treatments. And those companies have committed to making their drugs available at significantly reduced prices so that their availability is there for patients in Africa as well. And so the African Access Initiative model is based on the demand and the needs and interests of our partners in Nigeria and our other countries. So if they are prioritizing access to innovative medicines, those medicines are certainly part of our access program.
Alrighty.
We're coming to the end of our program right now. So unless there are any other urgent questions, and I would certainly welcome anyone here to reach out directly to BVGH. Our contact information is available on our website. We'd be happy to take any questions offline, and we'd be happy to partner with anyone that wants to contribute to improving cancer patient outcomes in Africa, whether it's providing training, expertise. We're always looking for partners that are interested in funding and supporting training programs. But I'd just like to thank everyone today for joining us. It's been a pleasure.
Hello.
Hello.
Hello. Yeah, this is Felicia Williams. Just before we close up, I have a question. It's the program is about ending. The question has to do with the issue of sustainability of this program. For any program to be sustained, are there strategies to ensure that this access program is sustained in northern Nigeria and the whole of Nigeria?
Well, I think that's such an important question, and thank you for that question. You know, sustainability and building a program that is that's built on the current infrastructure and the current systems, health systems within Nigeria is central to our model. And sustainability and scalability are very high priorities. And this program was built on what currently exists in Nigeria, and it's also not dependent on external partners like BVGH. We're using the regulatory system, the supply chain system, the pharmacists, and the demand at the hospital level to provide access to these medicines. And we're building a model around kind of central organizations like the Central Bank of Nigeria, so that in fact, this program and this access initiative is truly sustainable without BVGH or without other international players involved.
Hello? Hello?
Hello?
Hello? Yeah.
Yeah, so on that note, we are now at the end of our session. I'd like to thank everyone for joining us. I'd like to thank you for the questions. Please do, if you have further questions or would like to connect with BVGH offline, our contact information is available on our website. If you'd like to connect with Dr. Mohammed in Kaduna State, we'd be happy to provide his information as well. So thank you very much, everyone. Stay well in these challenging times, and we look forward to partnering with you and working together to improve cancer patient outcomes in Africa. Thank you.
Thank you very much.